Bom dia. This morning we are going to be talking about a topic that needs more focus in our journalism community. And that topic is investigating health issues. As journalists, we know that we investigate things that harm innocent people or make them ill. So today we're going to be talking to 3 journalists who investigated health issues in a way that brought about change in their countries and on a global scale. So we're going to start our conversation today with David Gonzalez of Venezuela, whose investigation into poor equipment led to changes. So, David, I'm going to let you talk a little bit about your series that ran this year and last year in El Nacional.
Hola, buen día. Gracias a todos por estar aquí. Comienzo con una breve introducción. Mi nombre es David González. Yo trabajo para el diario El Nacional, que se publica, es un diario de circulación nacional que se publica desde Caracas, Venezuela. Nosotros, constituimos una unidad de investigación hace poco, aproximadamente año y medio. Así que tenemos un equipo que está, comenzando en estas actividades y no formamos parte, de los periódicos de América Latina que tienen gran tradición publicando trabajos de investigación, como La Nación de Costa Rica, La Nación de Buenos Aires o aquí la Foria de Sao Paulo, ¿no? Les quería hablar un poquito, de el entorno, que es difícil conseguir información en Venezuela. Cada vez el Estado y el gobierno ha ido avanzando más a una situación de opacidad en la información, incluso datos públicos que deberían ser de muy sencillo acceso se tratan como una información casi que clasificada. Entonces ese es más o menos el contexto en el que nos estamos moviendo, una unidad de investigación joven que está entregando uno de sus primeros proyectos en un diario venezolano de circulación nacional. Aquí comienzo mostrándoles esta foto que les enseña un grupo de pacientes que está haciendo una protesta en un hospital de una región venezolana que se llama Carabobo. Esta es una fotografía de un diario que se llama El Carabobeño. Tienen pancartas en las cuales están reclamando por la paralización de uno de los equipos de radioterapia y ellos están esperando por ser sometidos a radioterapia para tratar el cáncer, son pacientes de cáncer, y el equipo del hospital público donde ellos deben acudir no está funcionando. Aquí ustedes pueden ver a una paciente que tiene un tapabocas y está conversando con los periodistas acerca de la situación. O sea, esa paciente no solo está lidiando con su enfermedad, sino que también está lidiando de la manera inadecuada en la que la está tratando el sistema público de salud en Venezuela, que debe proveer atención gratuita para la gente, para los enfermos. Cuando comienzas a hablar de cáncer en Venezuela, también, además de fotos como la que les acabo de mostrar, puedes ver testimonios como los que estamos viendo. Este es un conductor de autobuses de Caracas que está diciendo: aquí uno se muere si no está pilas, que es una expresión local que traduce que si no estás muy atento en una situación de alerta, continua, tú puedes perder la vida por las mismas características del sistema de salud. Hay que tener suerte, es una cuestión de suerte de acuerdo con él, y no esperar a que te hagan todo. Aquí tenemos a una mujer, este es un paciente de cáncer de próstata de más de 50 años. Una mujer que es Inés Alayón, que cuando le preguntábamos por su testimonial, también es caraqueña, de Caracas, de la ciudad capital de Venezuela, nos señalaba, me preguntaba si la terapia se detiene, ¿qué va a pasar conmigo y con lo que tengo adentro? Son del tipo de testimonios que ahorita mismo, si salimos a hacer un recorrido en Venezuela, vamos a conseguir entre los pacientes que sufren cáncer y requieren radioterapia. Para finalizar esta parte introductoria que nos ubica un poco en el tema que estamos tratando, les puedo decir que el cáncer en Venezuela es un problema de salud pública, es un problema de gran escala y que está asociado a muchísimas muertes. Está ubicado entre las primeras 3 causas de muerte en Venezuela, junto con afecciones cardíacas, un mal de muchos de nuestros países en América Latina, que es la violencia criminal, el delito, que causa muchos homicidios, y el cáncer está, colocado entre las principales causas de muerte en el país. Hablamos de 20.000 fallecidos anuales y a un aproximado de 44.000 diagnósticos cada año. Aquí les pongo esta frase que dice que la interrupción de la radioterapia implica graves riesgos para la salud de las personas que no están recibiendo el tratamiento. La mayoría de los oncólogos, de los doctores con los que hemos consultado sobre este tema, nos señalan que las interrupciones largas no deberían pasar. Y estamos hablando de personas como las que ya les mostré, que pueden esperar 4 o 5 meses antes de encontrar un centro donde aplicarse la radioterapia, o que tienen que estar viajando por distintos puntos de nuestro país buscando un centro que les permita recibir citas. Nosotros, por ejemplo, en agosto del año pasado estuvimos trabajando otra vez en este tema y en alguno de los centros de Caracas, que les recuerdo es la capital del país, no es una provincia remota por allá, estaban tomando citas para las radioterapias para el año 2014. A partir de ahora, concluida un poco la introducción para ubicarnos en el tema, les voy a explicar qué exactamente hicimos, los resultados, cómo lo hicimos y algunas lecciones si me alcanza el tiempo. El que hicimos, esta es una mujer, aprovecho antes de comentarle el que hicimos, es una mujer con cáncer de cuello uterino y aquí se lee claramente en español, equipo de radioterapia a media máquina, que es una expresión para decir que está trabajando con muchas fallas, con muchas interrupciones. Un día a medias y al día siguiente parado. Eso es lo que traduce la expresión que está en este. Esta mujer, nosotros hablamos con ella el año pasado y cuando volvimos a conversar con ella este año nos dijo que varios de sus compañeros, digamos, de lucha, 2 de ellos, no varios, corrijo, 2 de ellos habían fallecido, ya no estaban con ella. Es como un combatiente que va viendo morir los soldados que están alrededor. Pues comienzo a explicarles el qué hicimos, hablándoles de una admisión oficial, así le pongo, una declaración de la viceministra de Salud de Venezuela, que dio hace muy pocos días, el 23 de agosto del 2013. Ella lo hizo en la televisión pública venezolana, que en general es un foro para que los funcionarios del gobierno algunas veces desmientan las cosas que están siendo publicadas, dicen que los periodistas estamos atentando contra la estabilidad del país. Bueno, son fórmulas que son usuales en algunos de nuestros países. Y a la funcionaria se le pregunta a la periodista, según reseñas del diario El Nacional, que es donde, digamos, son los trabajos que estamos publicando, se mencionan 19 salas que están presentando fallas con estos equipos. ¿Esto es cierto? Le preguntan, ¿hasta qué punto? ¿Cuál es el trabajo que en estos momentos está realizando el ministerio a fin de solventarlo? Esa es la pregunta que le hacen a la funcionaria y cuando todos estábamos esperando que nos dijera, bueno, esos señores del Nacional, etcétera, 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 ella responde los elementos que yo les quiero poner para que ustedes entiendan el sentido general de la historia. Estamos seguros de que lo único que hay que hacer es reactivar el convenio con la hermana República Argentina para que el mantenimiento preventivo y correctivo de esos equipos que están dañados se continúe. Esta frase incluye varios elementos claves de la historia. Hay que reactivar, puesto que el convenio, ella de esa manera está diciendo que no está activo. Ese es un primer punto. El segundo punto es que está suscrito con la República Argentina, un convenio que involucra a Venezuela y a Argentina, y después se habla del mantenimiento preventivo y correctivo de equipos que se admite que están dañados. Para nosotros fue un poco sorprendente que ella diera esa declaración con ese grado de honestidad. Después ella añade otro elemento crucial de la historia que tiene que ver con que si bien nos podemos quejar de que es cierto que estén dañados, tenemos alguna fuera de servicio, es lo que agrega, nunca hubiesen estado si no se hubiese hecho la inversión enorme que el presidente Chávez planificó. Y es verdad, estos equipos de las 19 salas que estamos hablando forman parte de una de las, quizás la mayor iniciativa del Estado en 30 años para dotar a los hospitales públicos que, como les dije, prestan servicio gratuito en Venezuela con equipos para hacer las terapias radiactivas para cáncer, pues las radioterapias. ¿A qué corresponde esto? Esto, como ustedes ven, lo dice la viceministra el 23 de agosto. Pues, y los puntos claves de esa declaración están contenidos en un trabajo que nosotros publicamos un año antes. Durante un año no hubo nunca una declaración oficial que acerca del contenido de nuestro trabajo. ¿Cuáles eran los elementos de ese trabajo? Pues sí, Venezuela había establecido con Argentina en 2004 un convenio por más de $85 millones para compra de equipos para 19 salas públicas. Una de las cosas claves que nos hacían ver a los pacientes en la situación en la que se los he mostrado y los testimonios que ustedes les he leído, es que los contratos de mantenimiento de servicio técnico de esos equipos tenían una vigencia de 5 años y estaban vencidos. Comenzaron a vencer entre 2011 y 2012. Es decir, que las personas que ustedes vieron antes estaban padeciendo por un problema del vencimiento de los contratos de mantenimiento y las garantías de unos equipos. O por lo menos se puede señalar que ese era un factor de peso en la situación. ¿Qué es lo que les acabo de decir? Que las fallas de los equipos se podían relacionar con ese déficit de mantenimiento y con otros factores de infraestructura. Por ejemplo, en Venezuela se han hecho cada vez más frecuentes los apagones, las interrupciones del servicio eléctrico, y eso daña mucho los equipos si no están debidamente protegidos. Otros compromisos del acuerdo era construir y remodelar salas para instalar apropiadamente los equipos, y hay un punto aquí que les resalto en rojo, que es que el Ministerio de Salud, a pesar de que la evidencia que obtuvimos con nuestro trabajo nos señalaba que había sido advertido del próximo vencimiento de los contratos, pues no logró renovar a tiempo esa contratación. Hicimos publicaciones en 2 etapas, la primera en 2012, que la principal fue el trabajo que les acabo de mostrar, y la segunda etapa que muestra cómo un conjunto de organizaciones van verificando la Comisión de Salud de la Asamblea Nacional, institutos de investigación de las universidades venezolanas y otras instituciones que a un año de nuestra publicación también hicieron sus propias evaluaciones y llegaron a la conclusión de que muchos de los equipos fallaban. La de la Asamblea Nacional, que es el equivalente del Parlamento, es el Parlamento venezolano, llegaba a la conclusión de que de las 19 salas solo había 5 que funcionaban apropiadamente. Les hablo un poquito del impacto para después decirles un poquito cómo lo hicimos. Esto provocó una rápida respuesta de la Vicepresidencia Social Venezolana, que es una instancia del Gabinete Superior al Ministerio de Salud para dar respuesta. En el debate parlamentario, incluso los parlamentarios del propio gobierno, este que les señalo se llama Henry Ventura, comienzan a hablar de una posible omisión de la ministra anterior, la ministra que llevaba el convenio y la posterior, con respecto a la no renovación de los equipos. Se han presentado denuncias penales en la Fiscalía para establecer si hay responsabilidades penales, porque evidentemente algunos de los pacientes pudieron haber muerto por el déficit de atención. Y después, bueno, todo esto que les comento es de la apropiación colectiva del tema. Sociedades científicas que antes no conversaban del tema. El tema en realidad era bastante desconocido en Venezuela hasta que hacemos ese trabajo sistemático para hacerlo. Les digo algunas claves de qué fue lo que hicimos y cómo comenzamos. El presidente Chávez, que muchos de ustedes conocen, seguramente los latinoamericanos más, bueno, un liderazgo muy fuerte que hubo en Venezuela, fue un enfermo de cáncer que falleció en marzo pasado. Pues el presidente se trató, la mayor parte, digamos, el personal de confianza que él identificó para tratarse el cáncer estaba en Cuba. Es decir, el presidente no se trató la enfermedad en Venezuela prácticamente. Y en nuestra política es muy polarizada, hay mucha gente que ama a Chávez, otra gente que se le opone radicalmente. Estamos viviendo como una polarización, a pesar de que ya está muerto, todavía existe esa polarización. Pero en redes sociales circuló esta carta en la cual una paciente le señalaba al presidente que por favor viniera a Venezuela para tratarse el cáncer como cualquier persona común. Cuando nosotros leemos esta carta nos avergonzamos porque no teníamos el conocimiento preciso de la situación y nosotros comenzamos a estudiar. Es una carta escrita en términos muy duros, pero que sí nos movió una fibra. Cuando comenzamos a estudiar si eso efectivamente era así, te encontrabas con varias cosas. Te encontrabas con imágenes como las que ya le enseñé, te encontrabas con pacientes que vivían por ciudades de Venezuela y te encontrabas con que la prensa estaba haciendo, ya voy terminando, estaba haciendo una cobertura fraccionada del tema, no presentaba una visión de conjunto. E incluso había periódicos y columnistas y articulistas que señalaban que el presidente perfectamente se podía tratar el cáncer en Venezuela, lo cual no es una mentira, pero tampoco ponía en el primer lugar de importancia la situación de todos esos pacientes que estaban padeciendo dificultades. ¿Qué hicimos? Mirar las declaraciones oficiales. En general, había un discurso que apuntaba a señalar como si las 19 salas estuvieran plenamente operativas sin ninguna falla y como si existiesen planes para ampliar la red de cobertura. Cuando uno examinaba esas declaraciones, ya voy terminando, te dabas cuenta de que había centros que se mencionaban, se incluían en esas listas y que no habían sido concluidos. Se mencionaban salas que tenían precisamente estas fallas constantes y se hacía, digamos, no se hablaba, no se admitía que había un problema con la contratación. Entonces aquí fue como un poco el tema de desagregar el relato oficial y poner en cuestión a ver si lo que nos están diciendo los funcionarios era verdad o no. Entonces, bueno, la hipótesis era que el convenio de Venezuela-Argentina no había resuelto la situación. Hicimos un trabajo, porque es muy difícil acceder a información oficial, con esto termino, que nos permitió establecer a través de los proveedores argentinos que prestaban el servicio el tema de las garantías. Ellos lo admiten en sus páginas web y en documentos internos. Y a partir de allí realizamos todo un trabajo que básicamente fue un trabajo de campo, lo más masivo que pudimos, para terminar de confirmar cuál era la situación y descubrirla al público para incorporarla como un elemento de debate. Trabajamos más o menos 13 personas en esa primera fase. Algunas se dedicaron más a trabajar con los proveedores, otras se dedicaron a trabajar con los hospitales, los pacientes y profesionales que manejaban las máquinas, y fue justamente por este lado. Esta es una empresa venezolana que estaba asociada a los dos proveedores argentinos principales, Philips, les estoy hablando de la filial de Philips en Argentina, la que nos termina de confirmar la historia luego de preparar una entrevista, digamos, que iba a ser como una aproximación bastante hostil, pero finalmente la compañía termina admitiendo todas las cosas en vista de la información que ya habíamos recogido en hospitales, otros lugares, más lo que habíamos conseguido a través de la navegación en Internet. Bueno, termino diciendo que resaltando la importancia de estudiar los temas, porque no siempre en sociedades como la venezolana existe la posibilidad de que funcionarios estén dispuestos a alertarte sobre una situación como esa, pero eso en algunos casos se puede compensar siendo sensible a las cosas que uno ve en el entorno, estudiándolas y tratando de aproximarse de la mejor manera. Esto nos lleva a diversificar fuentes, y lo digo para sobrevivir como periodistas, no quedarnos paralizados, y incluso aprovechar al máximo, pensar personajes que uno no sabe si existen y después tratar de buscarlos en la realidad a ver si existen como fuentes. Y la importancia de trabajar en grupo, donde, digamos, cada pieza de información es totalmente relevante y totalmente importante para componer toda la historia. Lo dejo hasta aquí por cuestiones de tiempo y estoy abierto después a cualquier aclaratoria o duda que les haya quedado. Muchas gracias.
Thank you, David. We are going to take questions at the end of all the presentations because some of your questions might involve more than one presenter. I'd next like to ask Catherine Iban, who's an independent journalist who did a lot of work for Fortune magazine, on a very, very extraordinary story about drugs that were drug company in India that had falsified some testing. We don't know how many victims there are of this particular fraud, but perhaps millions of people who were harmed or perhaps even led to their death. So, Catherine, tell us about your long, long investigation.
Hi, it's nice to be here. Let's see. How do we get that up? But this is not my slide deck. This is not my slide deck. Okay. Okay. How do I get to the first slide? Yeah, it's not working. Yeah, this is not the first slide of my presentation. There we go. Thank you. So the story is called Dirty Medicine, the Epic Inside Story of Long-Term Criminal Fraud at Ranbaxy, the Indian drug company that makes generic Lipitor for millions of Americans. I don't know if you've heard of Ranbaxy. It's a giant Indian generic drug company, and it literally makes medicine for countries around the world. I would like to say just in introduction that I think there's a lot more here, and I think you'll see that in the slide. So if anybody would like to investigate this company in your countries, I would be happy to help in any way that I can. So the story started a long time ago, in 2008. So I cover pharmaceuticals and healthcare, and I began hearing from a lot of my sources that the generic drug marketplace was like the new Wild West. I also kept hearing about a company called Ranbaxy because I had heard that the FDA, which is our main drug regulator in the United States, was investigating this company, but I didn't really know why. Then in 2008, I got a call, a sort of unusual call from the host of a radio show on NPR called The People's Pharmacy. And I had been on his show before talking about my stories, but he had said to me, you need to investigate what is wrong with these generic drugs. And he used to be a big advocate for generics because, of course, everybody wants generics. The patients can't afford the brand name. So there were many doctors and pharmacologists and clinicians who were advocating that patients have an option of generic drugs. However, once our drug supply became more and more generic, this radio show host kept on getting calls from his listeners and emails saying that these generic drugs were making them incredibly sick. People who were on antidepressants who got switched from the brand name to the generic began to feel suicidal. People who had been stable with heart medicine on a brand name were switched to a generic, and they were having relapses of their condition. So he said you should investigate. But I really didn't know sort of where to begin because it's incredibly hard to prove generally what is wrong with generic drugs. It seemed like a pretty big topic. So I began to look at some of the standards that the FDA uses to evaluate generic drugs. There were a lot of red flags right away. So the first problem is the FDA's definition of bioequivalence. And I'll try to be quick because I know I don't have a lot of time. But this is the brand name range. So this is drugs are evaluated as to how quickly they reach maximum concentration in your blood. But what the FDA said is, okay, you want to make a generic, you have to meet a certain range. So the generic can be 20% below or 25% above the brand name concentration in the blood of the active pharmaceutical ingredient. So right away, you were talking about, all the doctors and pharmacists are saying, oh, the drugs are exactly the same. So the first indicator was, well, the drugs are not really exactly the same because there's this range permitted. And furthermore, if you are switched from one brand of a generic to another brand of a generic, you could be moving across a 45% range, right? Because you get one generic over here and another generic over here. So suddenly you could see how patients would become very unstable on their generics. Then I found out the medicine can have different, they're called excipients, which are other components of the drug product. So the binders and the fillers and the other products in the drug, those can be different. And as well, the time release was different. They can be absorbed at a different rate. So it's like one source told me if you're taking an antidepressant with a time release feature, it could be like the difference between sipping one gin and tonic over 2 hours or gulping down 4 gin and tonics in 20 minutes. Like that was some of the effect that the patients were experiencing. Now, this became the center of my story, which is the FDA's review, and I couldn't believe this because everybody says, the FDA is the toughest drug regulator in the world. They review company-generated data. That's how they evaluate the quality of the drugs. So Ranbaxy, let's say, submits data, the FDA looks at it, says it looks good, and they approve the drug, but they never test the drugs, okay? So effectively, it's an honor system because what if the data is no good? And that's what I uncovered at Ranbaxy. Here was the other gigantic red flag. So right now in the U.S., 40% of our generic drugs come from India. A total of 85% of our whole drug supply is generic. Most of those are from overseas. Now, the FDA only inspects the overseas plants once every 11 years. And they tell the companies in advance that they're coming. Okay, whereas with the manufacturing plants in the U.S., they go every 2.5 years, and those are surprise inspections. So, you know, it was clear that there were a lot of reasons to think that that these drugs might not be good. So in 2009, I ended up doing a story for Self magazine, which just looked at the patients and some of their reactions. I had a lot of very dramatic stories. I interviewed clinicians, and a lot of the medical societies in the U.S. Were issuing statements to their doctors saying, we're not sure if these generic drugs are so good. One thing that they were very concerned about are drugs that are called narrow therapeutic index drugs. So those are for conditions like epilepsy or for heart conditions where the dosing has to be very precise. So what they're concerned about is if you have that 45% range I showed you, maybe their companies, maybe their patients are going to be negatively affected by that. So I did this story, but I felt that I still hadn't really answered this bigger question, which is, what is wrong with the drugs? And if there is something wrong with the drugs, why is there something wrong with the drugs? And I sort of knew that to answer that question, I would need to get deep into a company. I would need to really get inside one of these generic drug companies to understand what was going on in the manufacturing process. I had mentioned the company Ranbaxy in this story and had given some details. So about a month after this story ran, I got this email. And it was from a source who called himself $4 Refill. I didn't know who he was. And $4 Refill is basically like if you go to Walmart to refill your generic drug prescription, you're going to pay $4. So he was saying to me, I'm interested in what you wrote. For a long, long time, I didn't know who this person was, and I can't even tell you to this day. I can't tell you who he is. But what he ended up doing is I got from him, ultimately, laboratory data. Hundreds, thousands of pages of laboratory data with no explanation as to what the laboratory data meant, which meant that I had to learn how to manufacture a generic drug to understand what the documents were telling me. And it was a little complicated, I have to admit. As I did more reporting, I also got internal documents. So I got internal emails from inside the company with executives talking about problems that they were having. And these internal emails and documents were still very unclear. They were hard to understand. But like, for example, so this one, what's super interesting about this one is the CC on it. Brian Tempest was the CEO of Ranbaxy, okay? And I got a lot of internal emails where they were CC'd to the top guys in the company. So this one says, summary is as follows. So they're having a problem because they have to register the drugs in different countries in the world. And this email is saying, summary is as follows. Data is not available for any of the products. What I understood this came to mean is that they had not tested these drugs. and the data that they had submitted to the companies to get approval for their drugs was totally false. They had fabricated data all around the world to regulators. So he says, let's see. Okay, so they're trying to figure out, what do we do? What do we tell these regulators, because we don't have any data at all and they're asking for new data? So basically, once I got all these emails with all these names, I lived on LinkedIn for months. I mean, I could be like a promotional director for LinkedIn, because all I did was look up these Indian names of these executives on LinkedIn and look at their networks and try to figure out, as I was verifying the emails, who are these people? So some very interesting things happened along the way, because I started to cold call all of these executives who were named in these emails, and I was calling them all around the world. So here is one very interesting experience I had. So here was one email I got. This is really interesting. This guy, Marcus Malloy, I didn't know who he was, he is saying to the executives, he's saying, I will not bring any samples with me. Not only I believe this is company policy, but I personally do not feel comfortable bringing samples in this manner. So what I discovered is that they were, from all around the world, the executives of the company were being asked to bring brand name samples in suitcases into India, and they were smuggling in the samples of brand name drugs, okay? It was totally illegal the way that they were transporting these drugs, and basically these executives were being used as drug mules by this company. So the question was, why were they bringing these drug samples to India? And at one point, I even got a source who was the person in the U.S. who was buying the suitcases at Walmart. And the suitcases were lined up in an office ready to go whenever anybody went to India. And what I ultimately figured out was that they were using these brand name samples in the tests and pretending that the brand name was their own drug, right? So that by testing the brand name drugs, they created perfect data. And they said, look at our great data. It's exactly like the brand name drugs. These drugs are completely equivalent. But the tests that they were running were off of the brand name, if that's clear. So I had to figure out how to manufacture a generic drug. And what I needed first to do is find a way to sort of map out the whole process. So here you begin to develop the product. You do an initial, what's called bioequivalence study with a very small amount of the drug. So it looked like they were using the brand name samples for these early bioequivalence studies. So then you have to make a bigger batch of drugs. And what you're doing as you're testing over the course of 2 years or longer is you're scaling up production. So you're going to see if you can take what is sort of a small, easy-to-control process and do it on a commercial scale, because that's what you have to prove when you get approval from a regulator. Then they end up doing a commercial batch. This is the pivotal batch, right, to show that they can do a commercial batch. Then they have to do stability testing. They put the drugs in these big refrigerators that replicate different climates around the world. So like if they're going to submit the drugs to Sudan, they have to expose them to extreme heat over a certain number of months and see how quickly they degrade. So I was trying to figure out this entire process. And the idea is that finally, once they figure out to do all of this, then they submit their application to the regulators. But of course, what they were doing was falsifying a lot of this data so that they could submit their applications to the regulators very quickly. So in trying to figure out how does this how are you supposed to make a drug? And I really had to figure that out in order to understand what they were doing wrong. So I tried to find a laboratory that would let me come in to look at how drugs are supposed to be manufactured. And I found a laboratory in New Jersey that allowed me to come in and observe, and I spent a day there. And the cornerstone of good manufacturing is documentation. You document everything. So this was a facility where literally no whiteout was permitted anywhere in the entire facility in case anybody was going to try to erase any data, right? You can't erase data, you can't change data without triggering an investigation in this facility. And so literally you have a company that is completely fabricating data, shredding data, so I began to understand the enormity of what Ranbaxy was doing. So then, of course, it helped me to better understand how you're not supposed to make a drug. And I just picked out this slide, which is, of course, from Breaking Bad. You're not supposed to make a drug like this. But what is really, really telling to me is that when I interviewed the head of the FDA's Office of Generic Drugs, this is what he said to me. This was his quote. "The approval system requires the ethical behavior of the applicant. Otherwise, the whole house of cards will fall down." Okay, that is the head of the Office of Generic Drugs for the FDA. And what he's saying to me is this is a total honor system. We really don't have any way to detect fraudulent data. So I was beginning to understand a little bit more about Ranbaxy's profit motive here. And just a few words on this. Our drug supply is 85% generic. Our whole generic market is $68 billion. But the biggest issue was that for the generic drug company that files their application first and challenges the patent, if they get approval, they get 6 months of exclusive sales in the U.S. market. And so for a generic Lipitor, for example, which Ranbaxy got permission to make, that was could have been $1 billion. So their profit motive to accelerate the manufacturing process was to get this first-to-file status. And then once they got it, their bigger profit lay in undercutting the costs of manufacturing to make it, you're selling a drug at rock-bottom cost, and the manufacturing has to cost even less. So this is, just to show you, this is some of the kinds of data that I got. So here's a document for Brazil. And there's a huge Brazil story here, folks, that has not been told. So if anybody wants to do it, I'll help you. So here's the drugs that Ranbaxy filed in Brazil. Here's the strength, the biobatch size. Okay, this is the size of the production that they ran. This is the size of the production that they claimed to regulators they ran. But here's the biggest tip-off of the fabrication. They filed that they had made 3 commercial batches of each of these drugs, which you have to do. You have to say to regulators, we made 3 commercial-sized lots, and they're all good. They said they made 3 commercial-sized lots. The actual number of lots they made, 0. Okay? So this is one of the kinds of documents that I was getting from inside Ranbaxy. Here's another very interesting document. So look at some of the countries here. Algeria, I can barely even, Burkina Faso, Cameroon, Congo, Ethiopia, Guinea. So these are the drugs, the registration status under review. Now, look at some of the issues they're facing. Stability data of proposed formulation was made at our end since data for the proposed formulation was not available. What that means is we didn't test these drugs for stability. We made up the data. So then they analyze, well, what are we going to do about this? They estimate. You see here, look, the risk to patient is high. The risk to the company is low. And then they decide what they're going to do about it, okay? So this was, I'm talking hundreds of pages from all around the world of this kind of documents that I had. Okay, so I thought, what am I going to do with all this data? How am I going to figure out what this data means? So I thought, I can't go to a source who makes human medicine because this is such sensitive documents. I need to go to somebody who can help me interpret these, who maybe knows about this process but does not make human medicine. So I had a source who makes veterinary drugs. And this guy sat with me hour after hour after hour after hour and went through these documents over a course of months and helped me understand what the data meant. So here are a couple of documents from inside of Ranbaxy. A draft internal report. Data has been extrapolated and fabricated. Here, down here, the majority of products filed in Brazil, Mexico, Middle East, Russia, Romania, Myanmar, Thailand, Vietnam, Malaysia, African nations have data submitted which did not exist, or data from different products and from different countries have been submitted. Okay? The obvious question was, what did the top executives know about this and what did they do about it? The answer was that they knew everything about it and they did nothing about it. So, my next slide. This was a document that was presented to the boardroom, the head of the board of directors, the executives at the company. So in the EU, stability data is suspect. API, which is active pharmaceutical ingredient, came from unapproved sources. Brazil and Mexico, this is most of the bioequivalence studies. The data does not exist. The data does not exist. The bioequivalence studies were phony. What is the risk? This is great. The issue is not just limited to HIV drugs. Rather, it is much more pervasive, affecting more than 200 products in more than 40 countries. Okay? This is what was presented to the top executives at the company at a boardroom meeting. Let me just, okay. So, do I have a few more minutes? Okay. So, I had a source named Kathy Spreen, who was a scientist in the U.S. And when she went to the company, she was thinking to herself, this company is incredible because I hold up this data on their generic drugs and it looks almost exactly like the brand name data. This company is so good. And then she keeps seeing this. The data is exactly the same. And then she's thinking, it's too good to be true. The data's got to be false. So then she starts asking her colleagues in India, can you send me the underlying data for these drugs that I'm looking at these charts? And the data never came because the tests had never been done and there was no data. So she began to suspect this. And she was especially concerned, as were many people, about the quality of the HIV drugs for Africa. And it was beginning to be understood inside the company that these drugs were no good, that they degraded too fast, they had substandard ingredients. So she told me she was sitting in a conference call and the medical director of the company, when she asked a question about the quality of the drugs, said, who cares, it's just blacks dying. So I knew that this quote said it all. You've got a drug company and the medical director of the company is saying that. That says it all. I don't have a lot of time, but I knew I had to get this quote on the record. She did not want to go on the record. I have never spent so much time in my life trying to get somebody on the record because I knew if I couldn't get her on the record, I would lose the quote. We couldn't run a quote like that to an unattributed source. And the long and the short of it was at the last minute, I did get her on the record, and I can tell you in the thousands of tweets that came out after my story run, that was the quote. Everybody tweeting, who cares, it's just blacks dying, what is wrong with this company? Let me just, hold on. The whistleblower who tipped off the FDA to what was going on wrote to regulators around the world, including the Brazilian regulators, the Anvisa officials at the Brazilian regulatory agency to say, he wrote anonymously to say you have to put a stop to this crime, and never heard back from the Brazilian regulators. Never heard back from the regulators at the European Union that he wrote to. Never heard back from the World Health Organization regulators he wrote to. He did hear back from the FDA, and it was the FDA that investigated his claims. So that's the Brazil. So just quickly, I'll say a couple of things about pursuing this topic. Here are some questions to ask. How does the drug regulator in your country verify quality? Do they do testing? Do they do inspections, or is it just an honor system? How often do they review or inspect? What are the patients saying about these drugs? Are there patient advocates or other people who are hearing that patients are complaining? You can look for lawsuits or whistleblower activity, seek out data through Freedom of Information, which I did. But I would say the two most important things I did to seek out impartial experts to help you understand the process, and also to try to see what you're reporting on. I spent hours watching manufacturing videos on YouTube. Of course, I requested a tour for Ranbaxy. They did not let me into their facilities. But wherever you can try to see what you're trying to describe, I would say that's the way to go. And in closing, I'll just say that possibly the worst part about this story is that I filed it and finished it in 2010. But because of an agreement I had with a confidential source, the agreement was that we would not run the story until the government had resolved its case against Ranbaxy. So that story sat in the Fortune queue for 3 years, and we could not run it. And because it was sitting there, basically I had to report it every day to make sure I wasn't missing anything. So I did report this story for 4 years, not through any choice of my own.
Thank you, Catherine. This story is extraordinary. I do want to announce that she's been given a book contract by HarperCollins to pursue reporting on this topic, and I'm sure she would love to talk to any of you who want to pick up in your country this data. I'm sure she would be more than happy to listen to and work with you in terms of pursuing this same topic. I'd like to introduce our third presenter, Rosemary Dwabuni of Pointer Newspapers in Nigeria, to talk about yet another lapse in how we serve our ill and that really causes a lot of pain and suffering. Rose?
Good morning, all. I am here to talk on investigating health issues in Nigeria. First, I will start with the background of Nigeria and its health system. Nigeria is a democratic federal structure. It has 36 states and the federal capital territory located at Abuja. The health sector is stratified into two categories. We have the private, we have the public. The public are those ones owned by government, while the private are those ones owned and operated by private individuals. Paradox of Nigeria's economy. Nigeria, like most countries of the world. It's a very rich country. It's a country that is endowed with abundance of natural resources. Unfortunately, half of the population lives below the poverty line of $1 per day. And this is as a result of mismanagement and corruption. And you can agree with me that there is no way these people can cater for their healthcare need adequately. Government on its own has not been able to provide these people with free healthcare services. Out of the 36 states in Nigeria, only 3 have free healthcare services for certain categories of persons: pregnant women, under 5 children, the elderly, people with disability, people living with HIV, and a kind of intervention program which is carried out periodically for people in the rural area. And these are the states that are offering these free healthcare services. You have Delta State there, you have Ekiti, you have Akwa Ibom. This was what really brought about this my investigation. Are these people actually getting these services free of charge in accordance with the plans of government? So I now went into an investigation which I titled Sabotage of Free Healthcare Programs in Nigeria. But it was published with the headline in an African report, Corruption Paid in Lives in Delta State, Nigeria. It was funded by Forum for African Investigative Reporters. So I used Delta State as my case study. You know, there are only 3 states offering these free healthcare services. And these are the free healthcare services in Delta State. They have for pregnant women, anybody who is pregnant from conception to 6 weeks after delivery, even with surgery, it is free of charge. Then under 5 children, any child below 5 years is entitled to free healthcare. Then people living with HIV, the rural health scheme, that is the rural health scheme that I told you that is a kind of intervention program for people at the grassroots where the poverty rate is very high. Every surgery, anything whatsoever is free of charge. The treatment, and it is for all categories. In as much as you can locate these services at the rural areas, it is just free of charge. These are the pictures from the activities of Delta State government that I use as my case study. That is the Delta State governor flagging up, interacting with children during the flagging of under 5 free healthcare program in the state. That is the same man declaring open the free maternal health. I don't know, maybe because he's a medical doctor. That is the internal view of the mobile hospitals that they normally use for the rural health scheme. They carry this mobile hospitals to different communities. This here you have the theater. That's the governor trying to inspect the facilities inside the mobile hospital. That is the mobile hospital situated in a community. And those people by the side are the people that came to assess the program. But there are certain surgeries that could not be handled right inside the mobile hospital. So they refer them to tertiary health institutions where they have designated doctors to attend to this patient. These are the ambulances that they use to carry them from the community to those tertiary health institutions. These are the people in the committee that just gathered to access these services. That's the medical doctor conducting surgery right inside the mobile hospital in a community. In my investigation, these were my findings. That nurses are always very, very unfriendly to patients because these services are free. Probably when it was not free, maybe for something that has to go for maybe $1, they can just say maybe collect $2. Then the additional $1 is just for their own pocket. But now it is just free of charge. So they now devise a means of extorting patients. They want to examine a woman. They tell the woman you have to pay for hand gloves and all that. You have the doctors and pharmacies. Most of them have their private clinics, private pharmacy shop. They divert drugs from government hospitals and patients to their own private clinics and pharmacy shop. Sometimes the doctors are not always there to attend to patients. So these patients, when they come to seek these services, they have no option than to go to private clinic where they will not see this doctor and now pay for these services. Sometimes some of them, because they have come with the hope that these services are free, what they now do, they didn't come with money. So some fall into the hands of quack, going to chemists and all that. You have the laboratory attendants. You go to for lab examination, they will tell you, oh, we don't have materials, but there are some that we have. They were charging patients, which is not supposed to be. You have the clerks chatting away during official when pregnant women will be on queue. You see them chatting away. Some get frustrated and they just leave. The techniques that I use to obtain information for these studies, apart from other techniques, I want to talk about the interviews that I conducted, the participatory observation, how I did it, then how I exploited my membership of committee. I tried to interview some persons at the community level who were beneficiaries of this program and how they were treated. I equally interviewed healthcare givers to know if the response that I got from this patient, if they were correct. But after the interviews, I discovered that the information I got were not just satisfactory at all. Because for you to carry out an interview in a hospital, you have to write to them. You don't just go there. When I started this job, I had my camera smashed, just bouncing into the hospital and started interviewing people. I didn't know that I have to go through a process, through a procedure. So I entered the hospital. You go to the public relations officer or the hospital administrator, who will now have to go to the chief medical director to take permission. Sometimes some persons will tell you, okay, madam, sit down, we will attend to you. By that, they have gone around to send information all over the delivery point that there is somebody around, so you have to maintain. Then in some places, they will tell you, you have to send your letter ahead of time, then send us your questionnaires. So in this process, by the time you come, they're already at alert. They're on the defensive. They already know what they want to tell you. They don't want to indict the system and all that. So when I did after these two techniques, I wasn't too satisfied again. So what I now did, after the interview, I wasn't satisfied. Then I now devised the participatory observation. Sometimes I would drink a lot of water so that my tummy will be big. Then I put on a maternity gown. I just throw like a pregnant woman to, any health facility. I will queue along with other pregnant women with my studio pregnancy. We collect cards, we chat, as pregnant women. We discuss, collect, exchange numbers and all that. I saw the way the card issuing attendants were behaving and all that. Then moving from one stage to the other, just like that. Even till when I went for laboratory tests, they brought out a tube. They said, madam, we don't have a tube. If you can go and buy, you buy, or you can buy this one. I will just buy this one. I said, no problem. I will go and buy. Then I left that place. Then I now went and sat down with the other pregnant women where we are supposed to wait to see the doctors. We sat, we are chatting and all that. And I discovered that in various hospitals that I visited, one thing was too constant. For a process that will start at about 8 a.m. in the morning, which is the official resumption time for Nigerian workers, until 12 noon, we would not have seen any doctor. Probably they were attending to their patients in their private clinics. So I did all that observation, and I noticed how they were doing, the nurses, the way they talk to people anyhow and all that. And the worst aspect of it was that people were dying in the process. There was a man who could not readily make just 8,000 naira available, which they wanted to extort. The man lost his wife. After he had sold, he rushed home, sold his television for 2,000 naira. Before he ran back to the hospital, the wife was already dead. Then, having used these two major techniques and other ones like some insiders giving me information and all that, I still checked through the health services, that were being offered in the state, I discovered that I still have not had any information concerning people living with HIV because they are always hiding. The hospital, even when they are on admission, they give them protection. They don't want the public to see them because of the stigmatization against them. I was now thinking, how do I do this thing? And nobody will want to tell you, oh, I'm HIV positive. Nobody does that. So I now remember that I belong to a committee in my church called the Hospitality Committee. What we do is that sometimes we pull funds together. We go to motherless home. We go to old people's home, prisons, hospitals. So we visit them. We present the items to them, share words of God with them, encourage them just to make them, feel happy. Then I now went to my church when we were holding a meeting, and I told them, I said, we've been visiting people. I said, I think we should visit, people living with HIV. Some of them, sometimes even their family members abandon them and all. I saw the idea to them. And they accepted because, one, I had a hidden agenda, which they didn't know. So we discussed, and they said, but the problem there now will now be fund. I said, no problem. Thank God this very project was funded by FAIR. So I gave them money, they bought the items, and the leader of the unit sought permission from the hospital management. They allowed us because, as church people, we have come to preach to these people, give them words of hope and all that. So we visited some of the hospitals. When we entered, you could see dejection, in these people. You could see that is sadness and sorrow in them. But when I entered, I started chatting them up. Oh, how are you? How are you? No. In fact, just feel happy. I said, who said you have HIV and all that? So we started chatting like that. Then our leader presented the items and talked with them. I asked if there is any of us that has any words of encouragement to give to these people. Then I now took the stage again. I started encouraging them. I said, whose report will you believe? If the doctor says you have HIV, that doesn't mean that you are going to die. And will you believe the report of the doctor instead of that of God? So after I admonished them, they were so happy. They became so lively. And some of them, by the time we were leaving, they were, Auntie, please, can you help me with your number? Auntie, please, can you help me with your number? My hidden agenda was, already working out for me. Then I gave them my numbers and we left. Before I got home, they were already calling me. So from there, we started chatting, we started interacting. Some of them opened up to me, and they were now telling me how they treat them, even in the hospital. They want to give them drugs. They say, open your hand, the nurses. They just throw it from, some distance. Some will just fall into their hands, and some will bounce just to the floor. They will pick it. He said, if your body there touches that of the nurse, then you are doomed for that day. They give them all forms of, verbal abuse and all that, verbal assault. So after I got, enough information to do my stories, and that was how I came with that article that was published, Corruption Paid in Life. There were so many. Even a woman was detained in the hospital after delivery just because he could not provide 2,000 naira. The woman was there for 6 hours. I explored another committee again, which they are going to show us inside the video clips that I have over there. Just like veterans have been telling us since, our recommendation, just have passion for this job. And once you are carrying investigative investigation, just be patient and be tolerant. Be friendly with people. That is the only way you can get information, because some persons may not, ordinarily, they will not want to talk to you as a press person. Some, they don't want to indict the system. They don't want to be the one, implicating anybody. Then, as investigative journalists, we must avoid temptations such as monetary inducement that may compromise our reportage. Rather, try to seek partners with donor agencies who could fund investigative reports to enable you carry proper and in-depth investigation. Investigative journalists, we should know that we are always, we are not just the friends of the people. So you should always be security conscious and arm yourself with existing laws and legislations on information gathering to avoid embarrassment and litigation.
Why are they like it?
If I carry my shit and go on, they don't do blood test finish. They will tell you, the next one man to give me. The same I go on, I go by the
Okay.
Now 4 times now. 4 times. Now I make me carry this one for the time.
Okay, so because now the state of teacher you may come.
What I want to do. That be the problem.
But we don't have doctors say all this is not free. Now I told this people not the child.
They don't tell the medicine now. They will carry the medicine to go step for chemist.
Okay. Where the carry the baby go?
Yeah, I the card on the first this month.
What you call it?
I said give them only paracetamol and they give us the strong medicine whether they say they go buy a fast, they will not get them.
How old is your baby?
Now 5 months plus.
5 months plus. But we don't have to say this is not free. Now I got to collect money.
Now only paracetamol and they give me.
She said she was giving us only paracetamol. Are you even understanding what they are saying?
But yeah, they're not the give, but yeah, they don't go give you for free.
It's not clear.
They don't give me for free, but
Okay, these women are complaining.
Okay.
Hello? These women are complaining. They went to the government hospital to seek these services, but they were not attended to. Some of them, they keep telling them, go to that place to buy the drugs after seeing the doctor. Some said that they went to the hospital, they didn't see the doctor. Some said that they got to that place, they were told to bring money for card, or that they don't even have cards, because some were even ready to pay. So that is just that. Thank you.
Thank you. So, thank you.